Dr. Cecily Anne, welcome to the show.
Thank you for having me. I am excited to be here.
Absolutely. By the way, this is the Real Talk podcast. My co-host, Dr. Will Cole, needed to take some time away. I'm like, dude, you gave me 6 months off. I did a sabbatical last year into this year. I'm like, you can take a couple months off. You're allowed. I have lots of friends out there that we can bring on to this show, talking about all kinds of things. And you have a topic that is obviously something that's a passion of mine as well. So we're going to have a great conversation here today. But you guys, she is the fasting doctor. Go check her out over on Instagram, the fasting doctor, Dr. Cecily Anne. You are a medical doctor. You work with a lot of patients, primarily maternal and fetal and obesity medicine. Are you with the Obesity Society? Is that the group you're with?
So I am a member, yes, of the American Board of Obesity Medicine.
Okay.
And then in my practice, I'm a private practice physician. And like you mentioned, I do high-risk OB, maternal-fetal medicine. But then I also have a preconception weight loss clinic where I apply lifestyle interventions to help women become healthier before they get pregnant.
Right. Well, and this is a big problem that a lot of women don't even understand. They see PCOS as blocking them from being able to have a baby, but they don't recognize what PCOS is, that it's actually an extension of the insulin resistance, which is where a low carb diet and some fasting could come in handy to help heal that. How do you have that conversation with those patients to explain it's just an extension of insulin resistance?
Yes. So the first thing, or I don't know, you can say kind of the nice thing is the first time many people come to see me, they have tried everything. There's still this misconception out there that people, if they're heavier set or what have you, they haven't tried, they don't have willpower, they haven't stuck to something. And you know what I mean? And people still think that, and people come to me and they're like, look, I have tried everything. I'm like, I know you've tried everything. I tried everything. It didn't work. I have willpower. I made it through medical school. I think I can be committed to things, but it didn't work for me either. And so I think just meeting them on that level and then talking to them about, look, this is what I did. And I'm not saying it's a one size fit all, but if you haven't tried it before, what do you have to lose? You don't have anything to lose. Yeah, you have just more knowledge to gain and whatnot. So people tend to be very open to that.
Well, and especially when you start talking about the dream of having a baby, sometimes that gets the attention of the woman, especially. So you're saying if I heal this, I can actually maybe get pregnant. So that gets some women excited about wanting to listen to what the good doctor has to say.
Yeah, and then there are, especially for people who are suffering from infertility and looking to undergo either infertility treatments or different methods like that, there are recommended cutoffs. Now, they're not end all be all. So you definitely can undergo different therapies, even if your weight is above a certain goal. But a lot of physicians like to see their patients do a trial of weight loss prior to using assisted reproductive technologies. So I think there's also another motivation there. So I really think it's the best time is to try to improve your health before pregnancy, because we know maternal health conditions increase the risk of complications. So a little, preventative medicine there when it can impact both mom and baby.
Well, and that's where I was going to go next with the question is a lot of women also don't even think about that how they eat and their state of metabolic health while they're pregnant actually is impacting the metabolism of that very baby. Like my mama, when she had me many moons ago, years ago, she was 300 plus pounds when she had me. So major insulin resistance going on and some other things. And then I was not able to be, I had to be C-sectioned out. And so then I didn't get the gut microbiome that I should have coming through the vaginal canal. People aren't thinking about those kinds of issues that, oh my gosh, I'm setting my child up to have to deal with the same stuff I've dealt with in my life. So why not fix it now and then you fix it generationally?
Yes, yes. And like when you're talking about like the field of epigenetics and all of that, there, we find that some of our health, a lot of our health begins in the womb, right? With just those influences that are around baby before baby makes any decisions for themselves about what they eat or anything like that, as, you know, adolescents, adults, or whatnot. And so that all of these things are important to consider. And that's why health is such a big tool, right? It's so key. It's more than just what you're doing right now in the moment. It has implications far reaching that many of us don't consider.
Isn't it interesting how a lot of pregnant women know you don't smoke? They
Mhm.
know you don't drink, or they shouldn't drink, or no, you don't do things that would put substances in your body that are obvious that would harm the baby. And yet they're sitting there packing their mouth with sugar and refined carbohydrates as if that's not going to cause the same or if not worse harm to that baby than those drugs and alcohol.
Well, and because we just don't talk about nutrition as much, and I mean just as a society, right? People still are, I think, resistant to, and that's changing, and obviously through people like you helping to get out the message. But I still think people underestimate just the nutrition aspect. People don't like to think of sugar as an abused substance, right? So if I talk about, you know, it's not great for your health to have excessive alcohol intake, or, you know, you shouldn't do drugs, right? We can all agree on that. But when we talk about sugar, because it is probably the most widely abused substance, right? We use it to cope, we use it when we're angry, we use it to do different things. And then that elicits a reaction. But because it's so common, it's hard to call out a behavior. It makes people uncomfortable, you know, because they're like, well, everyone's doing it. So how is this, you know, how is this bad? And it really is shifting the framework and really getting people to see that no, it does have impacts. Excessive anything, right, is not necessarily a good thing. And so we really need to try to reel in how many refined processed carbohydrates we're having.
Here, you're preaching my language. So now I'm curious because you're kind of unique because there's a lot of people out there now talking about fasting. I obviously wrote a whole book about it with Dr. Jason Fung
Uh-huh.
called The
I love
Complete.
your book, by the way.
What's that?
I, I said I love your book, by the way.
Oh, thank you. I would hope the fasting doctor likes The Complete Guide to Fasting. So,
Yes.
thank you. That's a high honor that you like it. And a lot of people are talking about it now, but you're the first person that I've heard explicitly talking about it as a modality while getting ready to be pregnant and then during the pregnancy. Before we get into that kind of controversial kind of part of this, tell us how you got fasting on your radar screen as a medical doctor.
So actually using fasting on myself, that was how I first was introduced to it. Now, when I start thinking about it back over the years, I met people who were intermittent fasting. We just weren't calling it intermittent
Just
fasting. And I kind of probably just looked at them like, oh, okay, that's nice. Good for you. You know, there was a night nurse that I worked with in residency. And I remember talking with her, and we were on night shift one night. And I was like, why aren't you eating? You know, like we're all going to get our food or whatever during night shift. And she was like, oh, if you eat at night, you get fat. And I was like, huh? You know, I looked at her and I was like, oh, okay. And we went about our way and ate, and she didn't eat. And, you know, she'd eat when she got off of her shift when the sun was up, right? And then when I talked with my great aunt, actually, who's about to turn 103, and I asked her kind of just to describe her, meal patterns, or just talking about her life in general. And she has always eaten at 8 a.m. and 4 p.m. and nothing after that. And she's been doing that probably since her teens.
Wow.
And I'm like, huh, okay. So there were these inklings here and there, but again, never really put it together. And so I ended up reading the Obesity Code. And then after that, like I said, I read the Complete Guide to Fasting, also read a book called Deep Nutrition, and kind of started testing those theories out on myself. And lost over 50 pounds. And so I figured, thank you, figured if it worked for me, again, not trying to make it sound like, one size fit all, because you definitely need personalization, but I felt like it didn't have anything, I didn't have anything to lose by introducing my patients to it, with the exception, maybe eye roller people maybe thinking I'm a little strange, but outside of that, I figured it's not going to hurt.
By the way, Obesity Code, for those of you watching or listening, that's by Dr. Jason Fung. And it was before we wrote The Complete Guide to Fasting. And then Deep Nutrition is by Dr. Cate Schanahan, who just recently re-released that book, an updated version of it, if you want to go check it out. I'm trying to get her on one of my podcasts soon. So hope to make that happen. But I'm curious, in your medical school training, and I talk to a lot of doctors all the time, you get very little teaching on nutrition. Now, fasting isn't specifically nutrition. Is it taught as starvation? I know a lot of the studies that look at fasting, the starvation studies. So I'm sure you looked at some of those studies. Was there any kind of emphasis on any kind of negative or positive that comes from periods without eating?
I will be honest, from in my medical school training, we didn't touch on nutrition much at all. So I guess a positive of that would be the things that I heard about starvation mode, honestly, and before I went deeper into that to see if that's even true, would have come from either trainers or, do you know what I mean? It wasn't like I had something pounded into my head over and over, kind of how, people are having to unlearn everything they've learned about saturated fat and whatnot, because that's been preached forever. I mean, I take that as a positive for me, in terms of at least I didn't have certain misconceptions drilled into me over and over. And so I think that also left me a little more open-minded to acknowledge, I didn't learn much about this. Now let me look at the data. Now let me look at things for myself.
So you were pretty much a clean slate with blissful ignorance.
Pretty much.
Well, I remember Dr. Jeff Follick one time talking about at one of the conferences. Oh, yeah, there was a study from the World War II era where they had these prisoners who they starved, and then they shot them with insulin to see what would happen to their blood sugar. And I'm going, oh, my God, did they not have peer review of these and ethics involved? And no.
No.
Well,
so at least we've come a long way in that aspect,
yeah.
because I think a lot of those studies hopefully would not occur today. But yeah, it's very interesting. And then with fasting, again, specifically, we didn't get, we just didn't get education on fasting when I was in medical school.
So now that you've embraced fasting, how long ago was that, by the way? Less than 5 years ago? Because my book's been 5 years old.
Yeah, no, about 2017.
Okay.
Yeah.
So the 3 years you've been hot and heavy, branding yourself. Again, you guys, The Fasting Doctor, go check her out on Instagram. She also has a website, thefastingdoctor.com. I love how you put on here information on this page. It's not medical advice. I feel for all you medical doctors having to that disclaimer everywhere. It's okay, don't misconstrue what I'm saying here. My opinion's not my profession's opinion. What do your colleagues think about this? Obviously, you have a lot of patient data now. You put this on a lot of patients. I'm going to get to the patients in a minute, but I'm curious about your medical colleagues. What do they think about Cecily putting all these patients on a don't eat for a period of time?
You know what? Actually, now, I would say within the last year, people are more accepting to it. One, because they're seeing people get results. And so I think it's hard to argue when you see the patient that you've taken care of for years, see me for 6 months to a year, and they're down anywhere from 30 to some patients 100 pounds, right? So I think that helps. The other thing is it has become, I think, more talked about. And so people, I think now is just a really good time where people are open to trying new things. Doctors have their patients coming in and asking them about it, like, hey, what about trying intermittent fasting? And so I've actually been pleasantly surprised, at least within the last 12 months, of the response. And I write a consultation letter. So whenever, a provider refers someone to a different specialty, part of it is you have to generate a report and type what you did. And I put in my report, this is what we do, this is the regimen, XYZ. And so far people continue to send them back to me. So it's going well.
It probably doesn't hurt that the Nobel Prize winner in medicine, what was it, 2016, I believe it was, did work on fasting and its effects on autophagy. That probably caught the attention of a lot of medical doctors that, wait, what? We can clear those dead proteins and just float around in there and don't go anywhere?
Right.
I wonder how much of that, because we haven't seen a similar embracement on a widespread scale of keto, even though it's been talked about a lot and it's out there in the culture. So what do you think so unique about fasting that makes it more acceptable than the latest diet fad of keto?
That's a good question. I guess maybe, I'm not sure. I think hopefully at a basic level, we can all agree that if you're not hungry, you shouldn't eat.
Right.
And I know that sometimes, it's very, I don't know, simplistic, and it's just a common kind of theme. We can probably all remember to childhood, maybe echoes of our parents saying, don't eat that, you'll spoil your dinner. Well, why not eat that, right? That's a form, again, of gut rest. And so over time, I think all of us have kind of had these spatterings here and there of people saying that. But again, we never really thought about it as a broader context or an actual health intervention or wellness tool or therapeutic effect. And so I think that could be helping the wheels turn a little bit. And people are like, oh, okay, well, maybe we can wait to eat a little longer than what we thought before.
I have a theory as to why fasting is embraced, and keto and paleo and carnivore and whole 30 and all these ones. All of those are specific diets, things you do, and they all are a thing that you really can't fit in a box of any other thing. They are their own entities. Fasting fits in every single one of them. So regardless of what your nutritional philosophy is, you can implore fasting. Now, some of those nutritional philosophies, it will be a whole lot harder to intermittent fast than others. But I think that's the common denominator that fasting fits into, and why maybe it's a little more readily accepted is you're not really telling people this is what you do. You're actually telling them this is what you don't eat.
Right. No, that's true. And you can apply it to, kind of no matter like what camp you're in or whatnot. And so that's a good point. That's definitely a good point.
So let's get into the patients themselves. So when you started talking, Cecily, about, okay, I'm going to have you have your meal at 8 o'clock in the morning, and then, I don't know, don't eat again till 4 o'clock in the afternoon. How does that conversation go over to a culture that has been accustomed to breakfast, snack, lunch, snack, dinner, snack, midnight snack? It's like all these feeding windows all day long. How do you convince them that not eating is a good idea?
Yeah, we do spend a lot of time on the revving up the metabolism and trying to, get them to stop thinking about that. Um, it's mixed. Some people are like, okay, great, let's go for it because they've heard about it in, news or popular culture. So that definitely helps. There are other people who kind of are a little skeptical and are like, okay, so when this doesn't work, what medicine can we try? And I'm like, wait, no, wait. How do you know it's not going to work? Like, we got to try it first, But either way, whether they're skeptical or, fully embracing it, I think that's where it's nice to kind of outline a plan. And so that's what we do. We're like, okay, I know this sounds, strange to you, but let's take the next 2 weeks and what eating window do you think you can realistically accomplish over the next 2 weeks? And let's just start there. Let's meet you where you're at. Let's just get used to the concept. And then going through kind of questions are like, okay, so I can drink diet pop while I'm fasting, right? And I'm like, no, you can't. I was like, so it's kind of that retraining and whatnot. But I would say about half of the people are really excited, and the other half, they definitely still end up doing it, but they kind of give me a look like,
Can I talk about that other half for a moment? I think the reason, and you already admitted this on this interview, the reason they're skeptical is they've tried everything and it didn't work before. So why would you believe that this new thing would be any different than all those other experiences? So it's almost at that point that you go, come on in.
Yep.
Your pain. I know everything has been so frustrating, and I know you followed it to the hilt and it just really hasn't worked. Now, let me explain. All those things are predicated on this kind of mentality, but let me tell you why this one is so much different than anything you've tried before. I think the marketing of the message is everything in this, and I know you do this, but I just those half skeptical people, it's almost like, let me proof of concept it to you. You commit to me X amount of time. I say 7 days. You're going to know pretty quick, whoa, like this is not as bad as I thought it was going to be. And or you get them keto adapted, and then they naturally fall into an intermittent fast without even thinking about it. And I know you do that as well. I just think it's because the kind of patient that comes to see you is far different than what a GP would have to deal with, which is a wide variety of people at all phases of life. You're getting the people in the worst of the worst mindset when it comes to diet and changes.
Right. Well, and you know what? Honestly, I feel very blessed that in the structure that I have, that I can block off time to speak with patients and able to work in that subset of clinic space. I know to a lot of people, 30 minutes doesn't sound like a long time. But honestly, that's a long time in a physician's office if we are doing nothing but talking for 30 minutes. Like we are discussing your different roadblocks, different mental barriers to different things, like just all of those things that go into why fasting in the past may have been difficult for you. Again, why are you reaching for that late night snack?
Yeah.
Why are you, what's going on? Why do you crave, your sugar, or why do you do, and so by being able to address all of the other reasons that people eat besides hunger, and then also slowly getting them to reduce their carbohydrate intake over time, it really does help them. They feel better. And I think when people start feeling better, even if the, scale hasn't moved yet, it's positive reinforcement to keep trying.
I'm curious because I know I talk to a lot of doctors all the time, and especially ones that delve into the nutritional health world with their patients. ICD codes. Is there a code for fasting or some modality like that? Or are you coding it for the disease and then doing your treatment? But then how do you get around standard of care that says use this drug for this condition? There's a lot of things that I think the general patient population has no idea the little hoops you have to jump through to get. And do you do cash are you a cash doctor, or do you do insurance? How does that all work?
Yeah, so again, I'm fortunate. I'm in an insurance-based practice, so that allows, I think, a lot of people to be able to see me that wouldn't otherwise be able to see me. And so that, again, I'm very fortunate for that. You kind of hit the nail right on the head. So we put ICD codes, and so their indications for seeing me are their comorbidities, right? So it's either they are referred to me because their hypertension or their diabetes or their what have you, and so that's how we go about it, and I use fasting and lifestyle interventions to treat the disease process. The nice thing is I always will tell them typically what what standard of care is. So for instance, if they meet criteria for bariatric surgery, I do let them know you meet criteria for bariatric surgery. However, you also told me you want to get pregnant in 6 months. So if you're actively trying to get pregnant, we should not do bariatric surgery on you. And that is also a known recommendation. If you are trying to get pregnant, I probably shouldn't put you on phentermine, right? Because you get pregnant while you're on that medication. And then, so again, the fact that I'm able to do preconception weight loss in people that are actively trying to get pregnant, we really shouldn't be putting those people on a lot of medications because we don't know what the effect is to the fetus.
Uh,
So it's
Such a position, Cecily, to be in there.
mhm.
Well, this is what I could do for you, and it will help you lose weight. But the baby thing, yeah, we kind of want to. So, oh wow, so that's incredible. Okay, so you can use that with your patients. That's awesome. Let's
Mhm.
get to the patients now, though, because this is where the rubber meets the road. They come to you because they see you as a great purveyor of knowledge about how to help them in their pregnancy. So you're helping them in the pre-pregnancy stage, and you're implementing some periods of fasting and lowering carbs and that kind of thing. How do you sell it that they need to be doing it while they're in gestation, while they're having the baby? Sometimes women freak out. Oh, I have to be eating all the time because I want to feed that baby. I don't want them to starve. How do you kind of get away from kind of the misconceptions people have about fasting?
Right. So we have a regimen that we'll introduce to patients while they're trying to get pregnant. And then when they are pregnant, we do change that regimen. So during pregnancy, I like people to focus more on the concept of gut rest, not necessarily that you're following a fasting schedule, if that makes sense.
Love it.
Um, and then we also focus on nutrition. And so this is why I do spend the time when we're working together for those 6 months to a year before pregnancy, also trying to address the nutrition so that they can also fuel that pregnancy and fuel that baby appropriately. So when I say gut rest, for instance, it's very well accepted and kind of known that, right, a lot of pregnant patients suffer from heartburn, right? Like that's just a thing. So what we've always told people is that, well, if you are having really bad heartburn and even during pregnancy, try not to eat 2 to 3 hours before going to bed, before laying in the supine position, right? Again, it's all how you say it. That is gut rest, that is fasting. So to treat some ailments in pregnancy, we've always said, do that. But no, we're not telling people necessarily to do a 24-hour fast, right, during
No.
pregnancy or anything like that. But yeah, I mean, if you're trying to improve your heartburn, you're going at least probably 12 to 14 hours, right? If you just cut off your meal 2 or 3 hours before bedtime. And so that combined with, um, doing some form of carb restriction. And when most people start to restrict their carbs, they're restricting the refined processed carbohydrates. And so, again, you're getting out some of the harmful substances, or at least decreasing them, and giving gut rest, which just sets you up for being able to have appropriate weight gain during pregnancy, not having excess weight gain, decreasing inflammation, and some of these things. So it's definitely a different approach that I take. So again, if I have people who are doing like 18-hour, 20-hour, 24-hour different fasting regimens like that, we do talk about when you're pregnant, we are going to dial that back a bit, but also don't necessarily fall into the trap where now you have to eat every 2 to 3 hours, because you don't have to do that. There's some specific conditions where, hyperemesis, if your stomach gets empty too long, it will worsen it and you will begin to have more nausea and vomiting. But outside of having a very specific condition, most people still do not need to eat every 2 to 3 hours. And you certainly don't need to eat right before you go to bed.
Well, and it's the whole concept of I'm eating for two. No, you're eating for one, and that one is feeding the other one, but it's not eating for two. That I think it's a bad kind of mode of thinking that a lot of women get into. Well, I'm eating for two, thus I need to eat more often, and that's not always the case.
Right. And if we look at it too, I mean, at least what we're currently recommending for pregnancy, you only need maybe about an additional 250 to 300. I've seen upper estimates, maybe an extra 400 calories a day. If you're just looking at, simple models like that. And so, again, that's not a lot of extra food, if you think about it.
Butter.
Yeah. So it's really, you're right. The eating for two, that doesn't mean double your portions.
A lot of women use it as an excuse to double their portion.
Yeah. And you definitely get the pregnancy cravings and things like that. And it's kind of like with everything else, right? I mean, there are going to be good days and bad days. I mean, I have days where my fasting is exactly on point, how I want it to be. And then I have other days where it's just not a good day. So, I think pregnancy is no differently, but I think just getting into that mindset that more often than not, I want to make sure that I'm fueling myself in a nutritious way, and that I'm not partaking in mindless eating, and realizing that the habits that I make do influence my children.
Well, and then you have the whole issue of gestational diabetes, which makes all these concepts all the more real, of cutting carbs, making sure you're controlling that blood sugar, and periods of digestive rest. I love the gut rest instead of fasting. It takes away the other F word, as I call it. So that way people are more willing to embrace it. So gestational diabetes, is that more common now? Are you seeing a lot of it, or is it just a rare occurrence?
No, we see, I mean, gestational diabetes as a high risk OB, that's probably one of my most common referrals and common consultations is for some form of diabetes, whether it's gestational or pre-existing. That's the other thing that I'd like to convey to patients. Because we try dietary modifications first, right? There's when we talk about gestational diabetes, there are people who are able to be diet controlled, and then there are people who are unable to have sugar control just with dietary modifications. And so then those are the ones that we end up having to use either a metformin, and if that doesn't work, then we end up having to go to insulin. But I like to convey to people that this gestational diabetic diet that we're telling you to follow, it's actually a great diet to continue after pregnancy.
Right.
And I try to phrase it in that way, because by the time you deliver, you've probably been eating this way at least for 6 to 8 weeks. And I said, by that point, it's a habit. And so don't just think now that the placenta's out, I'm going to go back to doing what I did before. Hopefully you've had time to make this diet fit into your lifestyle. And so why don't you just continue it afterwards? And so I really try to use that as a window for people to continue some form of carbohydrate restriction after pregnancy.
Well, and then you can even say, well, the odds and percentages of women who get gestational diabetes turning into actually full-blown type 2 diabetes is extremely high after you have have the baby. So you don't want to have that come on, continue the diet that you ate during. Yeah. And certainly by 6 to 8 weeks, hopefully they've seen proof of concept.
Mhm.
Hopefully they already started feeling better and going, wow, I can think clearly. I've never been able to think clearly. And it's like maybe subtle signs of, I'm not hungry. I can spontaneously go from 8 a.m. to 4 p.m., Cecily. And so I'm able to do that, like without even thinking about it. Whoa, what
Mhm.
magic have you put on me?
Right. And the other good thing is they also have data, right? A lot of people don't necessarily have access to glucometers or CGMs or things of that nature. Yes, but this is sometimes the first time that people actually see that what they eat does affect their blood sugars, because we don't see, unless you're testing your blood sugar, how do you know? Like
Yeah.
you wouldn't know, right? So
Hypo, hypo, you would know because you feel all the symptoms, but
right.
nobody feels hyperglycemia per se.
Right. And so um it's, the patients actually get that feedback. And so when I'm reviewing their blood sugars, I'll look at the sheet and I'm like, okay, I see an outlier, I see a 180 here. Tell me what happened. And I'm like, oh, I ate,
Right.
XYZ. And I'm like, okay, so just remember when you eat that, this is probably what's going to happen because of the data that you have provided me on yourself, right? So I think also being able to actually see it in black and white, what's happening, that also helps people as well. And then, as you mentioned, their risk of developing just overt diabetes, we usually say anywhere and upwards of 50% of women over the next 10 years after the diagnosis of gestational diabetes will go on to develop overt diabetes. And so having lifestyle modifications occur before that happens is huge, because once you develop diabetes, not that it's not reversible, we see people reversing it every day, but it just is another hoop you have to jump through. So why not, let's just prevent that hoop altogether.
Another issue that comes up for pregnant women when you start talking about carbohydrate restriction or fasting is the K word. So ketones are viewed as a negative thing when you are trying to have a baby. And yet, usually when people bring this up, I go, you realize when a baby is born, like their primary fuel source of their brain is immediately ketones, that they're already kind of in a mild state of ketosis at birth.
Mm-hmm.
So if it's a negative thing to their health, don't you think it would have manifested in a different way? And so how do you broach that subject about the K word, the people that freak out about it?
I think the issue is that, and again, I think people do the best that they can, but we do a lot of extrapolations and theories, if that makes sense. So we know that there is a condition called ketoacidosis, but people seem to not uncommonly mistake ketosis
Right.
for ketoacidosis.
Heard that somewhere. Yes.
Yeah, and so I think it's just kind of getting people to wrap their mind around it. The other thing that I will talk with people about, and this is probably more colleagues than anything, is that again, unless someone is testing their serum ketones, um, you don't necessarily know, like if they're not in tune with what they feel like when they're in ketosis or not, right? They may not know. And I would suspect that just because, again, you have people running around doing their everyday thing, that especially when we put people on a GDM diet, a lower carbohydrate diet, I'm sure a good percentage of those women are in ketosis, right? But we've never really tested them to prove that theory and then shown, right, look, their babies are just fine. But unfortunately in medicine, if since we haven't done those randomized studies, right, then people automatically pull back from that concept. And so what I tell people is, I'm like, look, we're focusing on a healthy lifestyle. We're focusing on a way of eating during pregnancy that is recommended for gestational diabetics, right? To restrict your carbohydrate intake. And so, as long as baby's growth is fine, as long as mom is doing fine, I'm not going to tell someone to stop eating a healthy way.
Well, and here's the thing, like most of these people coming to your clinic, unless they're already into learning about nutritional ketosis or fasting already, they may not even know to think about the K word. Like how many people walking around that aren't privy to this knowledge we're talking about here today, even think about ketosis in their body. Most of them in an overnight fast, even the most vegan of vegan who eats 30 bananas a day is going to wake up in the morning with a little bit of ketones
Yeah.
because of overnight fast. So let's stop pretending like people have this knowledge, I suppose. But you do have those people, and I know you have like those engineering minded type patients that go, well, I've tracked my ketone levels and they seem to be coming to a disturbing level. Is that going to harm my baby? And so you kind of have to walk them off the ledge a little bit.
Yeah, and it's just interesting. We still don't see, and I'm seeing more people talk about it now, or more patients talk about it now, but I think a lot of people are just hesitant to even raise the subject. I mean, and I'm glad that there are forums for people to realize that, you're not the only one who is concerned about sugar intake or maximizing metabolic health. It's when we, kind of take it either to ketosis or bringing it back to fasting. I remember when I first started intermittent fasting, I kind of just went about my way and just kind of went out for a walk at lunch. And, because I didn't want to talk about it, not because I thought it was strange, but it's like the minute you make some sort of lifestyle change, there's the peanut gallery. And honestly, I just didn't feel like dealing with the peanut gallery, right? And so the nice thing is, because people are feeling more empowered to having these conversations, then we can start really seeing how you can use dietary therapy and or combined with intermittent fasting really to help improve lifestyle overall.
So let's talk about after the baby is born, because this is another area where women start to freak out a little bit when they start lactating and they start breastfeeding their kids, which I have an interesting little breastfeeding thing for you here in a second. But
Okay.
It's amazing that they're like, oh my gosh, do I want to be cutting carbs? Do I want to be doing intermittent fasting? Is that going to harm the production of the milk, number one? Or is it going to put something in the milk that's going to harm my baby? How do you talk about that with your patients?
So the first thing that I tell people, and so, people may agree with me on this or not, but this is what I tell people, is that, during the first 6 to 8 weeks of having a newborn, I think most people can attest to, while they are the greatest joy, you are exhausted. You're just exhausted. And so what I like people to focus on the first 6 to 8 weeks is really establishing milk supply, because if you can get your milk supply established and you really learn how to breastfeed, a lot of people don't know how to breastfeed. And I know that seems very, counterintuitive, but with people, being told to cover up, and sorry, I'm very pro breastfeeding, so I might go off the ledge here, but with people being told to, cover up, or oh, you don't feel free to like nurse your child in public, and so in order to breastfeed you have to put on 15 different covers and find a quiet space and do all these things. Like, there's so many factors discouraging women from breastfeeding that I really like the first 6 to 8 weeks just to get your routine down, learn how to breastfeed. Let's focus on that. Then once breastfeeding is established, then it comes all back to supply. So if you, after 8 weeks of really getting breastfeeding down, you decide that you're going to start marathon training, you're going to go zero carb, and then you're going to fast all at once, then you'll hear people talk about, oh, well, see, that stuff was bad for my milk supply. It's not necessarily that stuff was bad for your milk supply, but you just threw like 3 different things at your body at once that you probably haven't done in the last 9 months. So I try to tell people to focus, do a stepwise approach so that you can continually reevaluate your milk supply. So an example would be if you are deciding to go low carb, but you find out that for the last, I don't know, 8 months or longer, you've been eating 300 or maybe 500 grams of carbohydrates a day. Well, your body in the context of breastfeeding will probably be a little shocked if you went from eating 300 to 500 grams of carbs a day, cold turkey, went to zero carb. And it's not that zero carb is bad, but again, it's a change to your body and your body needs time to adjust. So what a stepwise approach would be to, one, make sure you're staying hydrated, and then slowly reduce the grams of carbohydrates, and slowly reduce the grams of carbohydrates, all in the context of reevaluating your breast milk supply and doing gradual changes. Same thing would apply, right, if you're thinking of doing intermittent fasting, because again, you starting with a gut rest type approach, so whether that's 12 to 14 hours, making sure you're staying hydrated, and then keep an eye on your supply. And is your supply okay? Okay, then maybe then the next week you will extend by another hour or so. Oh, okay, is your supply still great? And then if you get to a point where you notice, okay, wait, my supply really did drop, then back off a little bit to where you found the right level for your body where your supply was fine. And so you have to continually reevaluate to make sure that your body is handling the changes in the context of breastfeeding.
Okay, so the breast milk story. Have you heard that there is a company now manufacturing a fake breast milk called Biomilq? Biomilq is the name of this company. And the purpose of it is a lot of women, even ones that breastfeed, eventually put the baby on formula, and formula has dairy in it, and dairy comes from cows. So we want to lower the climate change, global warming stuff. So we have taken human mammary glands and put it into this substance to mimic breast milk. I know, it's so crazy how people try to play God.
Heard that. I had not heard that one.
Yes.
No, I mean, definitely so there is a motto that fed is best. And so if for some reason you do have to use formula, right, we want to make sure that baby's fed. But I think we also have to get away from this kind of all or none theory. So I have seen women say, well, now I have to supplement with formula, so I'm going to stop breastfeeding. And I'm like, no, go ahead and whatever, even if it's just a few drops a day, like give baby your natural milk. And then if you need to supplement, then yes, supplement if indicated. But I would be hesitant to supplement with the milk that you're talking about.
What was funny, Cecily, is when I put that out there, I did a Jimmy Rants episode about it, and people are like, oh, well, that would be better than formula. And I'm like, what?
I don't know that would be. And again, I haven't, my whatever disclaimer is, I haven't looked into it. But just when you're telling me that, I mean, well, you see my face. That makes me a little, yeah, I would want to know a little more about that first before telling people to do that.
Yes, this look says everything, Cecily.
Like, what?
So before I let you go, a lot of criticisms about fasting is, okay, yeah, of course you're going to lose some weight. You're not eating any food. And of course, I've done some longer fasts than just intermittent.
Yeah.
And so people have this criticism about intermittent fasting and even extended fasting is, okay, yeah, you lose weight, but then once you start eating again, all that weight comes back on the body. Can you talk about how you explain to patients that it's this cumulative effect over time and not what you necessarily lose in the moment?
Right. And again, I think a lot of that goes into mindset. So when you first start fasting, as I'm sure all of your listeners know, you will lose water weight, right? You're going to diurese because as insulin levels come down, that serves as a natural diuretic. So you will see some water weight come off. But what I try to tell people is that what we're focusing on is a process over time, right? And so it's going to add up over time. So when you enter the fed state again, especially if someone's done, a 24, 48 hour or longer fast, when you start eating again, you will see weight gain. But again, that's more of the volume shifts, the water weight. So that doesn't mean it didn't work. Fasting is not a quick fix. And as much as people may want it to be, it is something that has to be done over time.
Right.
But that's what a lifestyle is. It's how you live your life. And you don't just live your life for 7 days and then you're just like, okay, I'm done. It's something that you have to continue to do. And I think once we set people up for that and then set realistic weight loss goals, like and again, sometimes my patients look at me a little bit like, really, I'm coming to see you just to lose 4 pounds a month? But I tell people that's the goal I want you to set. Now, honestly, I have many patients exceed 4 pounds a month, right? Especially if they're willing to improve their nutrition with intermittent fasting, we can see faster weight loss than that. But if we just wrap our minds around, I just want you to lose 4 or 5 pounds a month, that for most people is very doable with the subset of patients that I work with. And so that I think also helps to kind of keep them going and realize that I'm trying to set them up for something sustainable over time that they're going to continue to do so that the weight doesn't come back at the end of 6 months. There was I listened to a talk one time at a conference, and they paired it to why people say, well, ketogenic diets don't work. Well, if you don't shower anymore, say you do daily showers and you stop showering for a week, you're gonna smell. So does that mean showers don't work? Well, no, they work if you take them. If your breath smells and you quit brushing your teeth, right? So brushing your teeth doesn't work? Well, no, toothbrushing does work, but you quit doing it. So it's like intermittent fasting. And that's the first thing I try to tell people is like, look, I'm trying to set you up for a way of life. It is a way of life. And so if you abandon your lifestyle aid and go back to doing what you did before, don't be surprised if the weight comes back, right? I mean, that is what's going to happen.
Well, and people are so micro, like they see only in the moment. And if you take that 4 to 5 pound weight loss and extrapolate it over the whole year, that's 50 to 60 pounds. Like anybody would take that as a weight loss goal, unless you weigh 700 pounds and you need to lose a lot more. You're going to lose a lot more if you do fasting and keto, by the way. But I mean, even just the average person trying to lose about 30 pounds, you're going to do it in a year if you do this methodical way.
Correct. And that's what I try to set people up for. And once we multiply it over the 12 months, then people are like, oh, wait, 50 pounds in a year? I'm like, yes, 50 pounds in a year. So and it's hard, right? This is just how society is. We want instant gratification. We want it now. It should have come yesterday. But it's kind of refocusing that mind shame shift and how people are thinking. And again, once they start seeing that they met their weight loss goal for the month, they're interested in doing it for the next month. And again, people kind of become their own natural biohackers. It's amazing to see because they're like, well, this is what I tried since I saw you last time. I'm like, oh, tell me about it. What did you do? I want to know. So it's really nice. It really empowers people to really make fasting fit into their lifestyle. And I think that's important. You don't make your lifestyle fit into fasting. You make fasting fit into your lifestyle. And that's how it's going to be sustainable in the long run.
I love it. I love it. And probably after a while, you teach them the basic principles. Then they're like, Doc, I got this. I'll come back and see you in a couple of months just to check on metabolic markers, but I got this. I can do this.
Pretty much. And that's what, and the schedule of office visits really dictate that. I usually see people every 2 weeks until they've lost, 20 or 30 pounds. And then once that happens, I'm like, hey, you tell me when you need me. You don't need me? All right. If you feel like you're falling off, the bandwagon, or you're going through a prolonged stall, or, something has happened, just call my office back and we'll make an appointment and I'll see you. So my goal is for people not to continue to have to see me once they feel like they have it down.
Right. All right, Cecily, one last question, and I have to ask this one. Because you're all about intermittent fasting, and I'm a big believer in intermittent fasting. And obviously, with the caveats we talked about earlier for pregnant women, intermittent in the right, letting that digestion settle and the gut settle and rest. But for those of us, the rest of us, is intermittent fasting enough, or is there the right patient for doing some extended fast? Then, if you extended fast, how long is too long to extended fast? What are your thoughts?
Yeah, so I don't have an issue with extended fasting. What I usually do is I just kind of meet the patient where they are and see what they're, comfortable doing. But I still use the premise is if you're not hungry, don't eat. And so what I'll find there are a subset of patients who will naturally do that. And so when we're reviewing their fasting schedule over the last 2 weeks, and they'll say, you know what, I actually did a 36-hour fast because I wasn't hungry. And I'm like, great, how did you feel? Did you have any side effects or not? So when I work with people in the clinic, what the biggest thing is to look and see what medications they're on,
Right.
and to see what needs to be adjusted, because as you can imagine, the people that come to me often are on several different medications, and so we do have to spend some time looking at their medication list. And because there's some medications that are not safe to take on an empty stomach, so we have to kind of troubleshoot that. So I think a lot of times, it's easier to do medication manipulation on people who are fasting for 24 hours or less, because they usually have a meal in there that for those medications that can't be taken on an empty stomach, we can do that. But that doesn't mean you can't do extended fast. That just means you need to get with a provider who is familiar with being able to adjust medications in an appropriate way so that you can undertake an extended fast safely.
And even Dr. Fung and I put in our book that if you have a medication that you must take and you're under the care of a doctor adjusting the meds and everything, and yet you still have to take it, have a little small salad or just something little bit to
Right.
take that with, and then you get it, and it's so minimal calories, it's not really upsetting your fast.
Right. And that's the other thing people have to realize, because I think there's this misconception out there, especially when it deals with autophagy, that autophagy is this all or none phenomenon. But we know that basal levels of autophagy are going on all the time.
Right.
Because if not, we'd be dead. Right.
Right.
We can't live without that function. So then when we're talking about getting into extended fast, especially if you're trying to get some more therapeutic effects of it, if you do have, like you said, a small little, something, your body's gonna burn through that so quickly that you're gonna, you might, maybe if we want to be, play devil's advocate, you may downregulate autophagy briefly, but you're gonna go right back up. Do you know what I mean? And so those are all different things that people can work with their provider to do hacks on. So I think my biggest message with the extended fasting is that if you're on medications, make sure that you, again, hopefully you found someone who is accepting of fasting and willing to work with you on that. But presuming all of those things are true, just get them to adjust your medications appropriately. Maybe you need reduced doses, right? Because if you say you're on insulin, if you are reducing your carbohydrate intake, even for people who are doing ketogenic diets, tell your provider that, because you probably don't need as much insulin. So here you are taking your same dose of insulin and then you bottom out because you didn't have your levels adjusted appropriately. So there are definitely ways to make sure that you're undertaking your extended fast in a safe manner for those with medical conditions where you need your medications adjusted.
Right. Wow, what an hour this was. Thank you, Dr. Cecily Anne. Again, you guys go check her out, The Fasting Doctor, over on Instagram. And she's got thefastingdoctor.com, and you can find out all the great work she's doing. You do a lot of videos now. I'm starting to see you doing a lot more teaching videos. I was giving you pointers on microphones and lighting and stuff, and you're doing a great job already. And you are just an amazing inspiration for everyone in the fasting and low carb space. So thank you for all that you're doing. And thanks for being here today on Real Talk.
Yes. And thank you so much for having me.